virtual platform.
Exactly,
So
exactly.
societies also have their meetings on the web. So it's a challenging because it's a new. So initially it catched up, but I don't know how many people can devote so much time now.
Yeah, yeah, yeah. Sir, we are right on the time. And
Okay.
sir, can you just unshare so that I can just put one
Okay.
uh,
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 I
slide
I
about you?
yeah,
Just,
I have unshared.
yeah, yeah.
Okay, sir. So within 10 seconds, webinar is going to live. Hello,
Yeah,
Indrajit sir.
yeah, 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 yeah. I'm fine with it. So I'm just sharing the just a brief profile of sir.
Okay, sir. Ready? Hello.
Yeah, yeah, ready.
Uh, within 10 seconds, webinar is going to live. So, 3, 2, 1. Sir, you are live. Over to you, sir.
Yeah, thank you. Good evening, doctors. Today we are in the next series of our webinar on the recent updates on antiplatelet therapy. Also, we can get a lot of insights on the angioplasties that are very critical in nature, and when these antiplatelet therapies are going to be used and how to it is to be used, along with some kind of an history. So we have with us none other than the expert in cardiology, and I believe he doesn't require any introduction. His name is enough, Dr. D.K. Bahl. He is the currently is the principal director from the Department of Cardiology, Max Super Specialty Hospital from New Delhi. But he is known for his active involvement in the teaching programs, especially in AIMS, the New Delhi, as a dean, head of cardiology department and cardiothoracic department also. He is also associated with many of the clinical trials as a chief investigators and has lot of publication on his name, both in index national as well as international journals. It's needless to say that he had received numerous awards and recognition for his excellent work in cardiology. So, without wasting the time, let's uh, learn from the expert about the recent updates in the antiplatelet therapy. With this note, I welcome Dr. Wall out here for this program. Over to Dr. Wall for the program.
You have to I have to share these slides now. You have to make mm, yeah. Okay. Thanks, Indrajit, for your kind words, and I'm grateful to Lupin for arranging this continuing medical education program in this COVID era. These virtual platforms have become quite a rage, and it's a good way of in interacting with the audience and those who have logged in very well. Welcome and good evening to all of you. The topic I was given to speak today was on antiplatelet therapy for patients who undergo angioplasty. It's a big topic. I'm usually fond of history because I think those who don't learn from the history, as it is said, they are doomed to fail again. So, going to the history, whenever we talk of angioplasty, we always remember and admire this gentleman, Andreas Grundig, who introduced the technique of balloon angioplasty way back in 1977, and rest was a history. And after balloon came the coronary stents. Who introduced it is debatable. Maybe Sigwart, Guntarico Rubin, or Palmer Scars, or most of them were working simultaneously for different types of stents. So balloon angioplasty and coronary stenting gave birth to a subspecialty of cardiology called interventional cardiology. If you look at the timeline of history of interventional cardiology, it's quite impressive. We progressed fast. The complications rate came down. We could treat more patients. We were more efficient. The efficacy was increased. We were not only competing or complementing the bypass surgery, And in many fields, we have overtaken the surgeons. So this is thanks to the developments from balloon to bare metal stent to drug-eluting stent. In between came the absorbable stents, and now the third generation or so-called fourth generation stents with thinner struts. But what we forget in this timeline is that equally impressive was the development of antiplatelet therapy in these patients. We could take complications of putting a foreign body in the coronary arteries because we had a very potent antithrombotics and antiplatelet agents. And if you look at the timelines of antiplatelet, you will realize that this runs parallel to the interventional cardiology or coronary angioplasty timeline. So both have contributed for the efficacy and safety of coronary angioplasty and coronary stenting. Now, what I will restrict myself is to the oral antiplatelets. As we know, we have a time-tested aspirin COX-1 inhibitor, and then we have P2Y inhibitors like clopidogrel, ticlopidine, prasugrel, and ticagrelor. And for the time being, won't discuss today the intravenous one like protein 2B3 inhibitors or cangrelon or and won't delve into anticoagulants. So we know we started antiplatelet history with aspirin way back in 1897, and then in 1950 daily aspirin was given to 400 patients. If you look at in history, you are always fascinated that these 400 patient trials establishes a molecule and it becomes a household thing for all patients undergoing angioplasty. Soon it was realized that aspirin, a tablet of aspirin, is as good as a streptokinase or thrombolysis. Of course, you combine thrombolysis with aspirin and reduce significantly the vascular deaths, which every one of us knows. Not only in STEMI, non-STEMI patients also. The trials were conducted way back in 1985, aspirin versus no aspirin. So this history is not very long. It's a 40 years old history when we started with aspirin and first showed its efficacy in STEMI, acute coronary syndrome patients. One thing good in cardiology is, especially in interventional cardiology, is that every aspect has been studied. So we don't have to practice what is not evidence-based. We have evidence on everything. So let us see how the history goes from aspirin. And now in initial era of the stents and balloons, we realize that stent thrombosis is going to be a major problem because we are putting a foreign material in the coronary arteries and there are bound to be a thrombus over these stents. So if you look at this, is the first report of intravascular stents. You find out of 24 implants, 3 had a stent thrombosis. Now, if you look at the earlier trials of Benistent and STES, these are the 2 trials which compared bare metal stents with the drug-eluting stents and also the balloon angioplasty with the stents. You realize at that time, look at what was given: dipyridamole, warfarin, and aspirin. So this used to lead to a lot of bleeding issues because at that time we were concerned of taking care of the thrombus. So obviously warfarin was advocated and this used to lead to high bleeding risk. And then came this trial, ICER trial in 1996. So it is 10 years after that first trials of aspirin. Then people realized that if you combine aspirin with ticlopidine, which is an antiplatelet agent, it is much, much better as far as safety is concerned and the efficacy is concerned. So this trial compared ticlopidine versus warfarin on patients who were on aspirin. And it was realized that there was a lower myocardial infarction rate, lower TLR rate, and above all, the safety was established. It used to lead to a lot of less hemorrhages and vascular complication, which was a problem with warfarin. Then came several trials comparing the aspirin with the ticlopidine and warfarin, and all of them were consistent with the ICER results. So these are the several of the trials which were conducted, and all of them showed that the cumulative event rate is much, much better if you combine aspirin with ticlopidine, that is antiplatelet agents, rather than anticoagulants and antiplatelet agents. And then came the problem with ticlopidine was it had a lot of complications in the form of neutropenia and thrombocytopenia. It was a good antiplatelet agent. Then the next agent was tried, which is a clopidogrel. It's also a potent antiplatelet agent. And the ticlopidine was compared with clopidogrel, and it was found that the event rate was further reduced if you get clopidogrel instead of, and this is the classic trial which established it. And once this one trial comes, then there are bound to be several other trials establishing the same thing. And these days we do a meta-analysis when we have a lot of smaller trials. So if you look at the 13,000 or rather 14,000 patients, you find that in 2002, it was established that clopidogrel is better than ticlopidine, because ticlopidine, as I told you, had a lot of problems with neutropenia and thrombocytopenia. Then came this trial, PCI cure study. It looked at the cardiovascular death and MI rate at 1 year and compared the aspirin with the dual antiplatelet agents, clopidogrel with aspirin. And what again, it showed that there is a 31% relative risk reduction as far as cumulative hazard ratio is concerned. So these were the patients, subgroup of patients of non-STEMI who were studied in the cure study. So the patient who undergo angioplasty, this is the trial which established the role of dual antiplatelet agents. Then came the Credo, this again a 1 year results in 2000 patients. This established the role of giving a loading dose of 300 milligram of clopidogrel. So if you look at the history, I'm telling you the trials which were first conducted, how aspirin was, first we had warfarin, then aspirin, then we had aspirin with ticlopidine, then ticlopidine was replaced with clopidogrel. Then in clopidogrel, we found that loading dose, this is a Credo trial, 300 milligram loading dose. And again, we found it was better than not giving a loading dose. Not only in the stable patients, also in STEMI patients. These are the two trials, Clarity and Commit CCS, presented in the same year in ACC in 2001, one from China, one from Western world, and both showed that giving a clopidogrel in patients who present to you with STEMI is better than aspirin alone. So dual antiplatelet were by this time established, and it was established that we should give a loading dose of clopidogrel when the patient is undergoing angioplasty, especially for acute coronary syndrome. Then came this current trial. This showed what we practice today, that if you give 600 milligram of clopidogrel and give 150 milligram of aspirin for at least a week, as compared to the standard dose, that is 300 milligram and then 75 milligram of aspirin, you find that the stent thrombosis rates as well as cardiovascular death, MI, and stroke rates are significantly less as compared to the standard dosing practice. So this is the last trial which established what we practice today. That is not long back, a decade back, Lancet 2010. This is the current trial which established the role of giving a loading dose of 600 milligram when you use a clopidogrel. And till date, we follow this regimen whenever we are using clopidogrel. But if patient is not undergoing PCI, then there is no benefit of giving 600 milligram of loading dose in these patients. Now, then came this trial. This is called Triton TIMI 38. Establish a new molecule called prasugrel. We all know about it. 7,000 patients compared with 7,000 patients of clopidogrel. The loading dose was 60 milligram followed by 10 milligram. And this established that prasugrel, as far as primary endpoint of cardiovascular death, MI, and stroke rate is concerned, is much superior. There is a 19% reduction in the in the rates of primary endpoint. And also the stent thrombosis rates are significantly less if you look at the prasugrel as compared to clopidogrel, about 52% reduction. So the net clinical benefit, you calculate the bleeding as well as primary endpoint. You find there is a net benefit, but yes, there was more of bleeding problem because this is a potent antiplatelet agent, especially in patients who were elderly or who had a lower body weight. They are more prone to have a bleeding. If patient has a prior CVA or TIA, these drugs were not advocated. Then came this plateau trial, 18,000 patients with ACS, STEMI or non-STEMI. It compared the third molecule, which is we are using now, is ticagrelor, and it compared it with clopidogrel. The primary efficacy as far as composite of cardiovascular death, MI, and stroke is concerned was significantly less with ticagrelor as compared to clopidogrel. And fortunately, this trial also showed that the bleeding rate is not very different from clopidogrel if you use ticagrelor, which was very high with prasugrel, especially in patients who were elderly and weight was less. The stent thrombosis rate again was significantly less if you use ticagrelor as compared to clopidogrel. That means if you use in 1,000 patients ticagrelor, it will save 11 deaths, 13 MIs, and 6 stent thrombosis as compared to using a clopidogrel. And this is one trial which established this molecule ticagrelor, which is still there to stay. In between came smaller points, and in every points there was a trial available. There was some issues raised about PPI use, because a lot of people used to use PPI for gastritis in patients who were receiving dual antiplatelet agents. And it was found that omeprazole may be reducing the effects of clopidogrel, but this is the Cogent trial which established that no, you have to use PPI. You can use it because the cardiovascular events are same as placebo, with a significant reduction in gastrointestinal events. Now, then the next issue which was solved was, can we give ticagrelor in the ambulance before patient comes to the hospital, so that by the time it is taken for primary angioplasty, the antiplatelet effect is established. And this is the trial called Atlantic, which established that in STEMI patients, if you give 180 milligram of ticagrelor, it is much better. The stent thrombosis rate obviously was better in patients who were given it in ambulance rather than in cath lab, because it takes time and there was no increased bleeding risk. So if you have to give it in ambulance, pre-angiography, the ticagrelor is the agent which is recommended by the trials. Now we had two potent antiplatelets, prasugrel and ticagrelor. So obviously there was a competition amongst these two agents. And we have two large trials. Each was backed by the prasugrel, backed by Triton. The ticagrelor was backed by Plateau. The Plateau showed that there is a death from any cause was reduced with ticagrelor significantly, but it was not shown in prasugrel. Similarly, the bleeding rate, as I showed you, in Plateau was not significantly different from clopidogrel, while it was quite high in patients who received prasugrel. So indirectly, people thought that ticagrelor is a better molecule than prasugrel. And for all these years, for last 5-10 years, we were practicing and having this notion that ticagrelor is better than prasugrel. Then came small trials, head-to-head comparison of prasugrel with ticagrelor. This was not statistically a very powered trial because only had 1,000 patients. 30 days of follow-up showed that both molecules, the death reinfarction and TVR rates are equal. So you can use any of these agents, but this was not a very powered trial. Then recently in 2020 came this trial. This is published in last year. ICER reacted this produced a lot of reaction in the literature, because this showed that in 4,000 patients of ACS, ticagrelor was compared with prasugrel. 1 year of follow-up. It showed that in primary composite endpoint, a death MI and stroke rate were 36% less with prasugrel as compared to ticagrelor. And the bleeding was not significantly higher in both the groups. That means, contrary to the notion it established that prasugrel is better than ticagrelor. But then people realized, going into the paper, that this was not comparing the two molecules, because prasugrel, they were comparing two strategies. If you have to use prasugrel, then you have to use in different doses. In elderly and the people who have less body weight, you have to use 5 milligram instead of 10 milligram. That's why the bleeding rate was not significantly different in this head-to-head comparison. And it was an open label trial. So there are so many issues and limitations. But having said that, this showed that prasugrel cannot be ignored, that this may be a better molecule as far as antiplatelets are concerned, without producing more bleeding if you take care of the contraindications and reduce the dose in elderly and those with the lower body weight. Then the last word was not heard, because this is a recent JAMA publication, 62,000 patients, though it's not a randomized trial, it is a retrospective cohort, but this shows real world patients. It showed, compared ticagrelor as well as clopidogrel, the age-old agent which most of us are using. It showed that the net benefit was similar. So there was no difference whether you use ticagrelor and clopidogrel. Yes, it's only a hypothesis generating. This only shows that all the antiplatelets are having the almost the similar effect. One will have more protection from ischemic events, other will produce more bleeding events. So you cannot ignore one over the above, unless we have a head-to-head comparison, as we were doing in the ICER React, when we were comparing the ticagrelor with the clopidogrel or prasugrel. So then came the new concept. This is a concept in which this is said that if you have a patient in whom you want to use clopidogrel, because there is a resistance to clopidogrel in 10 to 25% of the patients, so you test them. So they very cleverly tested a strategy where genotype was guiding whether you give a ticagrelor or prasugrel. So once they have given the ticagrelor, the prasugrel was guided by the resistance. If it was showing the resistance, then they continued with ticagrelor. But if it was not showing, they switched over to clopidogrel, because clopidogrel is not only cheaper, leads to less bleeding problem. So if you guide it by genotypes, then clopidogrel will produce 22% less bleeding, which is known, which is expected, and the primary net outcome also will be better. So this is the trial which may show that in future maybe we will be individualizing which type of antiplatelet we use in a particular patient. Now let us discuss about some of the questions which are commonly asked whenever we are discussing antiplatelets in the patients who are undergoing angioplasty. The most common question asked is how long the DAPT should be given. If you look at the guidelines, by and large, it says that it should be given for 12 months, at least for 6 months in the patients who are stable. Now, there are several trials. Trials after trials have been conducted, giving DAPT for 3 months, 6 months, 12 months, 30 months. So if you look at the number of trials and number of patients studied, about 35,000 patients have been studied in this meta-analysis, and it showed that DAPT duration, if you exclude the DAPT trial, which we will be discussing shortly, the shorter duration of DAPT has equivalent MACE rate as compared to the 12-month DAPT. The longer DAPT can lead to less ischemia but more bleeding. So this is in a sense the summary of these head-to-head comparisons of 3 months, we'll say 12, 6 versus 12, 12 versus 30, 3, 6 versus 30, and so on. So let us first discuss what is the evidence that we should prolong DAPT beyond 12 months, which is the guideline recommended. Obviously, the theory is if you have a high-risk patient, like say left main, your 2 or 3 stents have been given, instant restenosis is there, graft angioplasty has been done, patient is diabetic, has a a lot of coronary issues. In that case, you want to continue a DAPT. So what is the evidence? This is the first trial which was published in 2013, DESLATE, 5,000 patients. This in fact combined two trials, real late and just late. So it's not a very robust trial, but what it suggested was that it doesn't matter whether you give it for, you prolong it, the DAPT, because the bleeding rate also was not significant. Then came this Arctic interruption trial again in 2013. Again, it showed that in 1,200 patients, that if you stop the DAPT and use only the aspirin, obviously the bleeding rate is less as compared to DAPT, but there is no significant reduction in death, myocardial infarction, stent thrombosis, or stroke rate. So giving it after 12 months may not be of any use. Then came this Optidual. Again, this trial showed that it did not achieve the statistical significance, but if you look at the data carefully, you will find it almost reached the statistics. So it showed that death, MI, and stroke rate, if you prolong it beyond 12 months, are significantly less as compared to a longer duration, as a shorter duration of DAPT of 12 months. The power of the trial was low, obviously. Then came this DAPT, much discussed trial, about 10,000 patients, published in 2014. Again, it suggested very interestingly that stent thrombosis rate is less, MACE rate is less, MI rate is less if you prolong the DAPT beyond 12 months as compared to stopping the DAPT, that is aspirin and clopidogrel, at 12 months. Interestingly, it showed that the death rates were higher in people who had a long DAPT. And it was suggested that this may be a chance finding, or the death rates are, when they look at the data, was more cancer related, more bleeding problem in those people. Because obviously bleeding is going to be higher if you give a DAPT as compared to aspirin in patients after 1 year. Obviously, the people looked at the meta-analysis because the individually trials were not statistically powered. So when you look at this meta-analysis, it's not very impressive that death, MI, and stroke rate can be prolonged, significantly reduced. Yes, it can be reduced somewhat if you prolong the DAPT after 12 months. Then this is a large trial, 21,000 patients on ticagrelor. What they did was they used, after 1 year, ticagrelor and the two doses, 90 milligram twice a day and 60 milligram. They reduced the dose also after 1 year to 60 milligrams so that the bleeding rate is less. And this trial suggested that in 1 year, if you tolerate the ticagrelor and you are additional risk factors, you are a high risk patient. If you use ticagrelor after 12 months also, there is a significant reduction in some of the points like myocardial infarction. The others or numbers are less, though they may not achieve the statistical power. So this gave rise to a concept in 2015 that you can, in a high risk patients you can take a chance and give a ticagrelor in the lower dose of 60 milligram, because that was as efficacious as 90 milligram twice a day after 1 year. Now, then came the concept that yes, now we have studied enough. There is a patient who is high risk for ischemia like ACS, diabetes, complex PCI, prior stent thrombosis, renal efficiency. And on the other hand, we have a person who has a high bleeding risk like anemia, prior bleeding, and who is on anticoagulants, who has a cancer, who is planned for a surgery. So you have to balance whenever you are giving antiplatelets in the form of dual antiplatelet agents, whether you want to continue it for a longer duration or a shorter duration. Now, what is the evidence for giving a duration of DAPT shorter than guideline recommended of 6 to 12 months? Now, starting again with 2013, this is a small trial, showed no difference whether you give it for the DAPT for 6 months or 24 months. Now, this is a reset trial. Again, 3 months was compared with the 12 months. Again, no significant difference. This is a trial again comparing 6 months with the 12 months. So several trials were conducted. Most of them were small trials. Statistically, they are not very robust trials, but they suggested that yes, you can reduce it, the duration in a patient who is more stable to 3 months also, and there won't be any significant effect on death, MI, stroke rate. Obviously, the bleeding rate might be lesser in the patients who are continued with DAPT as compared to single agent, but they are non-inferiority trials, smaller trials. This is a DAPT STEMI trial. Again, the trial, if you look at the p-value, there was no significant difference in death, MI, stroke rate, and TIMI major bleeding. Then this was a little larger trial, SMART date, 2,700 patients. 6 months were compared with 12 months. So again, this showed that if you use 12 months, which is recommended, the myocardial infarction rates are lower, though there is overall no significant difference whether you give it for 6 months or guideline recommended 12 months. So overall, if you look at these trials, what you will find is that shorter duration of DAPT in all these trials. There are several of them. Some of them I have mentioned here, comparing 3 with 12, 6 with 12, 12, 6 with 18, 6 with 24. And all of them showed that shorter duration of DAPT is as efficacious as non-inferior to giving it for a guideline recommended dose of 1 year DAPT. Then there is a very recent concept that patients who are a high bleeding risk, who are those patients? Elderly patient who had a stroke, hemorrhage, intracranial hemorrhage, renal disease, bleeding diathesis, liver disease, prior bleeding, active cancer, who are on NSAIDs or anticoagulant, or who are anemic with a low platelet count. These are the patients. By this time, we had these stents, which are third generation stent with a very thin struts. So these stents, they do not have a polymer which used to lead to problems of stent thrombosis. The strut size was less. So these newer stents, there was expected to be very low stent thrombosis rate. So why to give antiplatelet, which was recommended for the first generation of stents in the patient who is a high bleeding risk? So this is the first trial, leaders free trial. This showed that if you use a third generation stent, that is biofreedom stent, you can give a DAPT only for a month and follow with a single agent, that is aspirin, and they will be as good as bare metal stent, because usually it is recommended that if the patient has a high bleeding risk, give a bare metal stent, because in them you can give a shorter duration of stent thrombosis. So this trial established that third generation of stents can be given only 1 month of DAPT. And this was studied in 2 recent trials with a different companies, latest generation stent. This is a Medtronic Onyx 1 trial, 2,000 patients, high bleeding risk patients, again compared the 1 month of DAPT. And they found that 1 month of DAPT is enough, as was found in this Zines short trial, which is recently presented in TCT in 2020. It showed that compared to the historical control of Zines V, that it is non-inferior if you give it for a month. So this is establishing that in newer generation of stents, you may not require a 12 months of DAPT. You can shorten it to maybe 6 months, 3 months, 1 month, nobody knows it. But yes, there is a trend showing that all of these going in a one direction, that you can use if the patient is stable, not a very high risk patient and a high bleeding risk patient, then give it a DAPT only for a month and then switch over to aspirin. So I have shown you patients how you can reduce bleeding. One is obviously if you shorten the duration of DAPT, bleeding will be less. The second very important or rather interesting concept is de-escalation. De-escalation from potent agent like prasugrel and ticagrelor to clopidogrel after a week or a month, when the initial storm of thrombosis has been taken care of. And the third aspect is we will discuss is a very exciting aspect, that why to use aspirin at all. Now, These are the two trials for de-escalation. That is, this is tropical ACS, 2,600 patients, 1 year of follow-up. So 7 days they gave prasugrel. After 7 days of clopidogrel, they tested it, the platelet function testing. And again, if they thought that the clopidogrel patients are responding, then they continued with the clopidogrel instead of prasugrel. And then they compared the two groups, and they found that if you use clopidogrel with aspirin instead of prasugrel and aspirin, the primary endpoint of cardiovascular death, MI, stroke, and bleeding rates are significantly less. So this is what is called de-escalation. And this is the another trial, tropic trial, again with the ticagrelor and prasugrel, 1 month of these high potent antiplatelet agents, and then they switched it over to clopidogrel and followed these patients. And then they found there is a net benefit of a significant extent in the bleeding if you use clopidogrel instead of continue to use ticagrelor and prasugrel. So this is a important concept, may be very important where the cost is a matter, because ticagrelor costs. The ticagrelor also has a problem of some dyspnea and other things. Adherence may be a problem. So in the, especially the developing economies, this is an important concept, but needs to be tested in a larger number of patients, because this is very small number of patients as far as statistics is concerned. Now, this is a concept, whether you should use aspirin at all. What is the problem with aspirin? Aspirin has been used for ages. It leads to bleeding, especially the gastrointestinal bleeding. Now we have novel antithrombotics like prasugrel and ticagrelor. And then we have a novel stents available. So all these factors suggest that why use aspirin? Why not to use, instead of DAPT, why not to use only ticagrelor or prasugrel, which may take care of the antiplatelet aspects without the side effects of aspirin. And as you know, the aspirin has also been questioned for primary prevention. So this is questioning the aspirin for secondary prevention. This is the first trial, very robust trial, 16,000 patients, global leaders. A little confusing trial because they ventured to study it for 24 months. This is their endpoints. At the end of 24 months, they did not find statistically significant difference in mortality and Q wave. But at 1 year, where they should have stopped, there was a significant difference in endpoint. That means they gave ticagrelor and aspirin for a month, then followed by ticagrelor for 23 months versus a standard clopidogrel for stable and ticagrelor for ACS patients. So this is first trial which suggested that yes, there is a merit in stopping aspirin and continuing with only the ticagrelor or clopidogrel. Then there was a lot of question asked whether this is all the events were captured or not. So they educated the events and they published the glassy. So they found that even if you take care of these education, the results are almost the same. Then came this 7,000 patient Twilight study. Many of these patients were also recruited from India. These were high-risk patients undergoing PCI with deaths. Aspirin and ticagrelor for 3 months, followed by ticagrelor alone or ticagrelor plus aspirin. So instead of stopping ticagrelor, they stopped the aspirin and continued with ticagrelor. With this concept, what they found was the primary endpoint of bleeding was 44% reduced. So it's a very important concept, because fear was it might produce more of death, MIs, and stroke rate. But look at the composite endpoint, there's no difference. So you can stop aspirin altogether after 1 to 3 months and continue with ticagrelor or clopidogrel or prasugrel. So this is a TICO trial showing again the same things, ticagrelor for 3 months followed by ticagrelor alone instead of aspirin leads to less of bleeding. And these are the two trials with clopidogrel. These were the two trials with ticagrelor. Again, 3,000 patients, stop DAPT trial, primary endpoint. If you look at cardiovascular death, MI, stroke, and bleeding also, then you find there is a 36% reduction. That means you stop not the clopidogrel, but the aspirin and continue with the clopidogrel after a period of 1 month. And this stopped after 3 months. In the DAPT trial, stop DAPT, it was 1 month. Here it was 3 months. Again, the same results were produced. So this is a very important and a new concept. that instead of you give ticagrelor, prasugrel, clopidogrel, and DAPT for 1 to 3 months, and then instead of stopping the prasugrel, ticagrelor, or clopidogrel, stop aspirin and continue with the potent antiplatelet agents. Now, there is a meta-analysis which is done for all the smaller trials, 20,000 patients, significantly reduced this concept, the major bleed, which was expected, and similar benefit in thrombotic events. So there are lots of debates whether to give 3 months, 1 month, 6 months, which concept to follow. People have given the scoring system, precise DAPT score, DAPT scores. These are also available on WhatsApp, the scoring systems. So you can put the data and get a scoring system. If the patient has a high bleeding risk, follow the traditional approach of giving clopidogrel and aspirin for a shorter duration. If a high ischemic score, then follow it after 12 months, the DAPT can be concept. But you must remember the bleeding reduction is not only with antiplatelet. There are many other factors like radial access instead of femoral, the reducing the dose, as I told you, reducing the dose of anti-thrombotic agents if you are using, not to use NSAIDs, use PPIs. So all these concepts can lead to a reduction of bleeding, which is all of us require. We must remember that the progress in DAPT and the stent technology is going hand in hand. So we do not know what is affecting what. Maybe the stent technology is better available now. So the third thing I will like to discuss is the triple versus dual therapy. You know that many of these patients have atrial fibrillation who undergo a PCI. In atrial fibrillation, as you know, we want to give oral anticoagulants, while for PCI patients, you require antiplatelet agents. So simply, you cannot combine antithrombotic and antiplatelet. You can, but then it will lead to more of bleeding problems. So how to deal with a patient who has atrial fibrillation or say mechanical valve and undergoes an angioplasty and requires antiplatelet agents. This is the first trial which was studied. This is called VOICE trial. This studies warfarin. What they did was they compared the triple with the dual therapy. Dual therapy means with warfarin, give clopidogrel. And they found that if you do that, there is a number of bleeds are significantly reduced. So if you have to use both the agents, that is antithrombotic and antiplatelet, instead of triple therapy of clopidogrel, aspirin, and warfarin, use clopidogrel and warfarin. Similarly, this is a redual PCI trial. This again suggested that if you use this concept, this used dabigatran, they used in 2 doses, 110 BD and 150 BD. So instead of triple, if you use warfarin, clopidogrel, and aspirin, instead of that, if you use dabigatran and clopidogrel, this will be better. Then came this Pioneer AF study, much talked about study, 2,000 patients, 12 months of follow-up. They studied now, first was studied was warfarin, then was studied was dabigatran. This study rivaroxaban. Rivaroxaban was studied in 2 doses. One was 15 milligram, not the conventional 20, and another was 2.5 milligram twice a day, which is unconventional dose. And with this lower dose, they use the DAPT. So their concept is that you can use rivaroxaban with the antiplatelets for a shorter duration of 1 month, 3 months, 6 months. And as compared to the triple therapy, there will be a significant reduction in the bleeding events. And there will be no change in the ischemic events of death, rehospitalization, and stroke rate. So this is consistent, whatever the results we were getting. This is the newer trial. This is called Augustus trial, published last year. Again, showed apixaban versus warfarin and aspirin. So they had a 2 factorial design. So they showed that apixaban, using apixaban is better than warfarin, and using placebo versus aspirin. So if you have to use any of these anti-thrombotic agents, be it dabigatran, warfarin, rivaroxaban, or apixaban, then instead of using aspirin plus clopidogrel or ticagrelor, use only omit the aspirin part. So this is the last agent which was again tried, edoxaban. Surprisingly, in this trial, They did not achieve the non-inferiority, but the concept is the same, that instead of triple, give the dual therapy. Now, some aspect about non-cardiac surgery, all of us know that the guidelines recommend that for BMS, give 30 days of DAPT. For DAS, at least 6 months of DAPT before you take the patient for non-cardiac surgery, unless it's a dire emergency. And if patient is receiving prasugrel, stop it 7 days before surgery. And for ticagrelor and clopidogrel, stop it 5 days. There is some concept that you can bridge this gap with cangrelor, which may be a costly affair, but can be used, and then restart. They are recommending that low dose aspirin should be continued throughout. So the other aspect, smaller aspect, is a diabetes. This is a recent trial, THEMIS PCI trial. This showed that in diabetic patients who are stable angina patients, if you use ticagrelor versus the placebo, the effect will be better. So we have shown you the different aspects of antiplatelet agents and how the things have progressed. If you look at the PCIs and antiplatelet data, some of this may not be reflected in the guidelines. Whatever the guidelines we are available, as I discussed, that for drug-eluting stent, both the ESC and ACC recommend it for at least for no high bleeding risk if the stable patient for 6 months, if acute coronary syndrome for 12 months. This is the standard requisition, that is class A recommendation. Now you have to individualize the treatment. If patient is high ischemic risk, maybe prolong the DAPT therapy with all its caveat, whether you want to omit aspirin and go for the newer exciting concept of using only the ticagrelor or maybe clopidogrel. If the patient has a high bleeding risk, then use one of these newer stents and only use DAPT for a month or maybe 7 days. So that way you can individualize the therapy and take care of both the ischemia and the bleeding risk. Now, this is not all. Antiplatelet is not everything in the interventional cardiology and pharmacology. We have the PCSK9 taking care of lipids to a very, very low levels. The inflammatory pathway has been invoked in by canakinumab and recently by colchicine. Then we have an important concept of using SGLT2 inhibitors and GLP-1 agonist in high-risk cardiovascular patients. Then you can extend the DAPT by using a low dose of ticagrelor of 60 milligram twice a day in patients who are high bleeding risk but have high ischemic risk and no low bleeding risk. And then if you have to use anticoagulants, use a dual therapy and maybe use a low dose of rivaroxaban or apixaban. So these are the concepts by which you can take care of both the ischemia and bleeding. So as it has been said by Holmes, that great thing in this world is not so much where we stand today, because this is a dynamic ground, it will change, but what direction we are moving. So if you look at the history, as I have told you, the timelines of angioplasty and antiplatelets, we are moving in the right direction. And we have come a long way from aspirin and the balloon angioplasty advocated by Andreas Grubjik. And I'm sure if he was alive, he would have said that you have done well, my dear fellows. Thank you. Thank you for listening. If there are any questions, I don't know if there are in chat box, I may be able to answer them.
So there are 24 questions which has been there.
Okay, good. So let us go on.
Sir, first you have to stop sharing screen.
Okay, let me see how to do. Stop sharing. Okay, now it's okay.
Yeah.
Okay. So let us go for the chat. I can read them. So should I go one by one?
Yes, sir. Please proceed.
Okay. So the first question was, you showed aspirin as the backbone in antiplatelet therapy. However, recent evidence are suggesting aspirin-free antiplatelet therapy in long term. Please share your opinion on the same and how to categorize these patients. Good question. The concept here is that when you are using aspirin as a monotherapy. So once you have used the DAPT, whether you use aspirin with clopidogrel, prasugrel, or uh, ticagrelor for a period where the thrombosis is going to be higher, risk of thrombosis is going to be higher, maybe for a month or so, then instead of stopping the potent antiplatelet, they are, that is ticagrelor and prasugrel or clopidogrel, stop aspirin, because they are, of course, you are using single one. You are, so the concept is not contradictory to what is being advocated. So you are using aspirin as antiplatelet, or you are using a more potent antiplatelet as a single therapy. So I don't think the concept is contradictory, and I personally think yes, this is the way forward, and this will be the way forward. And I see that maybe after 12 months, ticagrelor in the form of 60 milligram in a reduced dose. Similarly, maybe others will come up with reduced dose and show maybe enough in the longer run. So they are not contradictory. Yes, they are a concept which is against our thinking. So it takes time before we can register them, and this is reflected in the guidelines. But I think it's a important concept and a good concept. So second is, do you believe in crushing? Oh yes, the people have used this. Trials have been conducted both on prasugrel and ticagrelor, crushing and non-crushing. I think that the trials are not powered enough. Neither they are important enough that we should bother about this. I don't believe in this is a micromanagement which doesn't lead to a significant effect, because statistically they won't have any power to detect that. What is the current status of IV antiplatelet therapy during PCI? Ganglirol is there, but I don't think is available in India. At least I haven't used it. Maybe very costly. So concept is okay. Like when you get the patient for primary angioplasty and you give ticagrelor these days or prasugrel, it obviously it takes time before the full antiplatelet effect is established, and that intervening period, because if you finish the angioplasty very quickly, there is an intervening period, and you can take care of that intervening period by IV antiplatelet agents if they are available. Concept is there, has been shown in one or two trials. The cost may be a factor, but we have not seen very significantly stent thrombosis. So I don't know whether you really require that or not. In very high thrombus rates, people still use these glycoprotein 2B3A agents, but the data is not very convincing of their use except in very high thrombotic risk. Recent ESC guidelines in non-STEMI ACS patients has given priority prasugrel over ticagrelor. What is your opinion on same while treating patients in real world? As I showed you, yes, the ICER trial showed that prasugrel is better, but then prasugrel has to be used as a strategy, that you have to reduce the dose in those who are elderly, those who are lower weight. You don't use it in patients who have a CVA history, and maybe in that situation prasugrel will be maybe better or maybe equivalent to ticagrelor. But as I showed you in the next real world, if you are asking me real world, as I showed you a 62,000 patients registry, uh, and it's showing that clopidogrel is as effective as ticagrelor. So I personally believe all these agents have their merits and demerits. The ticagrelor, the problem is twice a day use, so adherence will be a problem, and about 15-20% patients, dyspnea is a problem. Prasugrel may be a more potent agent, but has a bleeding problem, so you have to adjust the dose, which is very difficult. So both have their merits and demerits based on one trial. Some people have changed their practice, but I personally am a slow adapter, so I don't usually change whatever I am using. So I think even clopidogrel is quite effective, but yes, there is a problem of resistance, whether it is 5% or 25% or 30%, we don't know definitely. So there is a merit in that trial. It's a large trial, so it shows what it shows. What should be the antiplatelet strategy in patient with AF undergoing multi-vessel PCI bifurcation, etc.? It should be strategy should be same. As I told you, triple therapy, maybe in that case, if you don't comfortable at 1 month, you may stop at 3 months if the patient has no bleeding risk. But after that, you have to give a dual therapy instead of continuing with the triple therapy. Triple therapy can lead to a lot of problem. Whether you are an advocate of rivaroxaban 2.5 milligram, which is not available, or 15 milligram, whether you want to use apixaban, dabigatran, or maybe even warfarin. Warfarin, maybe the trial wise it doesn't show. So if not one of these NOACs with clopidogrel is what is recommended. But yes, if there is a complex angioplasty, maybe you can continue the triple therapy for 1 month or 3 months. Go for the de-escalation therapy or so on. So you have to individualize the patients. Very difficult to pinpoint in these particular situations what you want to do. Then we go to recently US FDA has approved ticagrelor 60 milligram for primary prevention of high risk CAD. Yes, with or without diabetes, are you implementing medical management of Indian patients? This was not the topic, that's why I omitted that trial. Whether it will be recommended for primary prevention in high risk patients, it depends. Primary prevention is a very open field. So Indian patients or non-Indian patients, it depends on if very high risk patients, whether you want to use a drug which can lead to a potential bleeding problem. I won't be recommending today to patient unless he is a very high risk, very father or mother had a very premature coronary artery disease, has a other problems, etc. I won't be recommending, but yes, in future, who knows, maybe ticagrelor comes. But ticagrelor 60 milligram BD for secondary prevention after 1 year, yes, I practice that. I find that useful. Before that was available in India, I even used to tell people you can use that. So does genotype mapping with clopidogrel is a practical approach? Not a practical approach. I have never used it. It will lead to cost escalation. So we continue to use clopidogrel without genotype matching. So we don't use it. That is a simple answer. Then Dr. Shahi asked, can ticagrelor be used in thrombolysis patient? Yes, it can be used. There is a trial called TREAT trial. I have omitted those trials because I restricted myself to PCI. But yes, there is a trial in which thrombolysis, ticagrelor has been used in patients who have been thrombolized. Then Dr. Pawan Goel asks, in high-risk patients with CAD and stroke and AF, would you choose ticagrelor? Now, again, there is a trial recently published for stroke patients. You can go through that trial. See, these antiplatelets agents have the class effect, so they will be used in any situations in which the aspirin or clopidogrel is used. How to use it is a matter of debate. Then comes Dr. Gaurav Jain. Doctor, in your practice, which antiplatelet you prefer to continue after 1 year? If I have to prefer, I will prefer ticagrelor 60 milligram BD, which is evidence based, or even continue with the DAPT of using clopidogrel aspirin if a patient is high risk without any bleeding problem. Fortunately, our patients are different from the Western world which we see. Our MIs are quite younger. The MIs which are seen in Western world are elderly people with a lot of other comorbidities, having a lot of bleeding risk, as compared to the Indian patients who are younger, not at that much of a bleeding risk, more of a problem of ischemia. So many people continue with the DAPT, that is clopidogrel aspirin, before it was being recommended or not recommended. In India, you will find many patients after MI continue to have DAPT. It has a downside, but people use. But if you go by evidence, 60 milligram ticagrelor has the evidence in big SS trial. Then is lost this. Dr. Gaurav Jain, Nectar. In clinical practice, Dr. Kapil asked, do you use precise DAPT and DAPT score to choose the duration? And I don't use these scoring systems, because once you have overall seen the patient, these scoring systems, lots of them are available, are helpful where the computer work is done. We see the patient so thoroughly, usually spend time, you know all the risk factors, so you can make a opinion and they will be as good as scoring system, but no harm. If you have sufficient time, you can use them. They are showing the same things which you take from the history and examination, and you come to know that this patient has a high bleeding risk or this patient has a high ischemia risk. That gives a more objectivity. The scoring system gives you more subjectivity, like a syntax score. How many of us are doing in the lab syntax score? But by eyeballing, you know that this is a high syntax score, this is a low syntax score. You may not be pinpointing the exact score. So I usually don't practice, but can be practiced, then no harm. Will there be a rebound ischemic risk on patients switched? Switch from DAPT to single antiplatelet after 3 to 6 months. Rebound ischemic risk. I don't know, maybe, but usually it should not be, because if you have done the PCI, you have taken care of the lesion, the thrombotic phase is over, it's better to switch over to agent which is less costly, which is less likely to produce bleeding. And there is some evidence. Evidence is very small, statistically not robust, but what is showing is this is an important concept, especially in country like us. Now the cost may be coming down, but when the cost of ticagrelor was quite high, so this was an important concept. Now when the cost will come down, the only problem with ticagrelor remains is twice a day use and some amount of dyspnea which it produces. Otherwise, it's a very good molecule. So the concept wise, it's okay. Whether rebound ischemia will be produced or not is not definitely, I can't answer that based on the literature. So I think this answers all the questions which I have in the chat box. If you have any other.
No, sir. Right now, we don't have any more questions.
So
any final remarks, sir, from your side?
Pardon?
Your final remarks.
Final remarks, I think I have given my conclusion. Individualize the patient, look at your patients, look at the ischemia risk, look at the bleeding risk, and choose your antiplatelet agents. These are the important concepts which we have developed. So in future, I think the shorter the duration, it will be, yes, definitely it will be shorter duration will be preferred. If you ask me, aspirin will be replaced, maybe yes, it will be replaced. Genotype will come, I don't think it will come. The rest of the concept I have discussed in detail. I think that should answer whatever is known in the literature till date.
Okay, sir. Thank you very much for coming out on the platform and sharing your experience with our guest doctors who have attended this program. It was a really wonderful lecture from your side, and the kind of evidences that you have shared with us was really a great one. I thank you on behalf of Lupin and all our viewers for attending the session. Wonderful session. Thank you very much.
Grateful to Lupin for giving me this chance to of interaction. I think Lupin is doing a great job by getting these CMEs done in this COVID era, so that people can virtually keep abreast with the recent advances. Thank you once again. Thank you.
Thank you, sir.
Okay.
Okay, sir. Thank you so much.